ALCL or ALK-positive ALCL, where it's uniform and strong in every cell. So this is not uncommon in peripheral T-cell lymphoma. In this case, it's a tumor that expresses cytotoxic molecules and CD8. Now, lymphoma that we see fairly frequently in British Columbia is this one, and what is referred to as AITL. Again, it's older adults. Generalized lymphadenopathy is typical, organomegaly. They may have rash, they may have autoimmune hemolytic anemia, and they can have polyclonal gammopathy. Remember the publication from Ahmed Dogan and colleagues and Peter Isaacson in Blood in about 2002. There are 3 different patterns that one can see, type 1, 2, and 3. And type 1 is a very early pattern, and as I mentioned on that second slide, can be very difficult to distinguish from reactive lymph nodes. We'll say a word about it. Characteristic clear cells, again, small vessel proliferation. It has a very characteristic phenotype as shown here because it is a tumor of follicular T helper cells. So BCL6 is expressed, CD10 is expressed, PD1 is expressed, and CXCL13. EBV is present in most cases, but it's not in the tumor cells, it's in B cells, large B cell blasts. And then characteristic FTC meshworks are very common. I remind you that you may find clones for T cell in here, but it is not at all uncommon to find immunoglobulin heavy chain rearrangements. And so that's particularly early on in the disease. B cells are driven to proliferate here, and they can be found to be clonal in a decent percentage of cases. And then very recently, those of you who are keeping up with your literature will realize that there's actually recurrent mutations in a gene that has to do with metabolism that's found in 20%. Very common to have trisomies in this disease too. So here's some characteristic images at high power. You can see this is a pan, I think that's CD5, I can't see from here. Or maybe it isn't, I think it is. Here you have the meshworks of CD21 that are very characteristic. You don't see this in any other tumor. Profound, you can see profound expansion of these follicular dendritic cells. And then as mentioned, very nice work from the Isaacson group again, expression of CD10 by these malignant B cells, very characteristic. Here we see again at higher power, you can see beautiful clear cells, all these small vessel proliferations, and characteristic expression. One of the things that's helpful as a hematopathologist is we see CD10 expression in germinal centers and in germinal center neoplasms. But in this disease, the expression is often very strong. And that's a characteristic finding. So CD10 is very strongly expressed. Here you have CXL13 and CD2, I believe. Again, hard to read from here. Occasionally you get lucky and you flow these cases. Here we have flow for CD20 and CD10. There aren't CD10 positive cells that are, or CD20 positive CD10 co-expressing cells. They're simply cells that are CD10 expressing but 20 negative. This is a very uncommon finding that we have flow on a case of AITL, but this is the case in which we did. And here you can see the immunohistochemistry with very strong expression. Now, a very important point that people need to remember again is that we see an expansion of B-cell blasts in this disease. They're not malignant, at least in the majority of cases. And when you look for EBV, the EBV is not in the tumor cells, it's in these cells. So the EBV is harbored within the benign B cells, which are driven to proliferate. That's a characteristic finding. If you have enough of these, that's where if you do molecular genetics, you will find clonal B cell rearrangements. But don't be fooled by that. In fact, there is a clue that you're dealing with this disease when you do PCR and you have both a T cell and a B cell clone. That's a very good clue that this is what you're dealing with. Here again, some nice immuno. This is on a case I saw in the last couple of weeks, actually. CD4 positive and beautiful PD1 staining and CXCL13. Now, Laurence de Laval, who's coming in 2 weeks for the course. I'm not helping to advertise, but I am apparently getting some money afterwards, some pesetas, for advertising this meeting that's coming up in 2 weeks. Did some beautiful work with Philippe Gallard, and they were able to document using gene expression that this is a disease of follicular T helper cells. And this is the disease, without giving away too many secrets, that we're sequencing right now in Vancouver in collaboration with Laurence and Philippe. And we're going to find stuff. What the gene expression data did that was very helpful is it allowed us to appreciate this overlap. So clearly there is an overlap in some cases that become very hard to diagnose, but at the level of gene expression, they are expressing genes that are characteristic of T follicular helper cells. We will sort this out in the next few years, I'm sure. All right. In the interest of time, and it's getting really late now, And I see some heads nodding. We're going to pick up pace here. We're going to talk like Leticia, Quintanilla, Martinez, Fend. So here's anaplastic large cell lymphoma, ALK positive, a disease that tends to occur in younger people, can frequently have skin involvement, and generally speaking is the one T cell type of disease that has a relatively favorable outcome. But any of the clinicians in this room will tell you, you definitely see cases, ALK positive AL cell in advanced stage that do not do well. And so not everybody does great. We'll show you some pictures instead of talking about it. It is a T-cell disease, as you know. It very, or not uncommonly, does not express CD3. It can express other T-cell markers, typically cytotoxic, can be EMA positive depending on where you live and how you stain, and ALK positive, of course, is characteristic. It's characterized as clonal, of course. There are a few exceptions, and the typical cases have a 2,5 translocation, but remember the presence of a variant translocation will give you differential staining with ALK, where it's not nuclear, it can be different. I took those slides out in the interest of time. So here we have a characteristic case here in the subcapsular sinus. I have no doubts that 20, 25, 30 years ago, these cases were coming through our clinics and were not being recognized. They had cohesive-looking infiltrates in subcapsular sinus, big ugly cells. This is before immunohistochemistry. These things were called primary unknowns, metastatic neoplasms, epithelial probably. I have no doubts that that was happening. But once the reagents came along to recognize these, we now are much more attuned to them. Now, everybody will have learned in medical school that the most vacuolated characteristic lymphoma is Burkitt's, which isn't true. The most vacuolated cells you see in any lymphoma are anaplastic large cell lymphoma. They always look like this in my experience when you do imprint preparations. Here I brought this just for Gabby with a nice CD30, but this is a case I took a long time ago. As I mentioned, CD3 is typically negative, but this is such a beautiful mirror image to show the young Cesarmans who were in med school, and I was told they're here somewhere, about how nicely you have life as a pathologist. So the reason I never went into radiology until PET scans came along, radiology is all black and white. Pathology is fun. Look, it's beautiful colors and very exciting field. And you get to make diagnoses. So here we have CD20, and you can see these cells right here, a little bit of residual lymph node, and then the tumor there, all nicely CD3 positive. But most cases, as I said, in my experience, are CD3 negative. Here you see again in a sinus, you can see cells sheeting out with CD30. Here's our nice stain again, and here's an ALK stain showing you staining of both the nucleus and the cytoplasm, characteristic of the 2,5 translocation. Here we see expression of cytotoxic molecules, which is present in the majority of cases. Here's a case from a series that Georges Del Sol and others published, where if one looked at that down the microscope, you'd think that was classic Hodgkin lymphoma. But in fact, when you look at it, it does have a few inflammatory cells, and it is kind of tricky, but in fact, it's ALK positive, EMA positive, and cytotoxic molecule. So some of these cases can mimic Hodgkin lymphoma, which is why immunohistochemistry is so important. Now, suffice it to say that we recognize anaplastic large cell lymphoma, and now, as of 2008, we divided into two groups, one of which is provisional. But I'll remind you that this ALK negative ALCL, although provisional, is a fairly frequent diagnosis. In contrast to ALK positive disease, these patients tend to be older, and they tend to have much less favorable outcome. The way I think of this disease is I look down the microscope and see the H&E, and I think anaplastic large cell lymphoma. And then the next thing I do is whether it's ALK positive or negative. So most of the cases that I call ALK negative ALCL are strong and uniform CD30 positive, but by definition are ALK negative. And they're the cases I would have bet one of my colleagues, cappuccino or a latte, that this is going to be positive, ALK positive, only to find out it isn't. So that's the way I use this category of ALK negative ALCL. The phenotype is T cells, we mentioned. It's typically cytotoxic as well, but most characteristic thing is shown here is it's ALK negative by definition. Most cases will be clonal, and remember, I had mentioned to you about next-gen sequencing. And I'd mentioned to you that Laurence and Philippe and I are doing a collaboration, and I said we will find things. So this was published in Blood in 2011 from the Mayo Clinic, where using next-gen sequencing, they discovered a novel translocation that had never been recognized before. And it's fairly recurrent in ALK-negative ALCL, but we won't dwell on it. So here's a good case. Again, you look down the microscope, you think that's going to be ALK-positive disease. You don't know the age, so you're guessing it's a young person, and it's going to be, and everything fits except ALK. It's negative. But look at the CD30 and remember back to that CD30 I showed you in the